Hello, my name's Amy Lampard. I'm one of the doctors in the adult safeguarding team at Sheffield Place, South Yorkshire ICB. I hope I've met most of you before, but if not, welcome. And I am the person that when you contact the ICB, I will provide the clinical slant and support for your safeguarding adults queries. Today, we're going to talk about non-fatal strangulation and suffocation, a really important topic and something that I think is quite new onto our radars. So, the definition of non-fatal strangulation is anything where external pressure closes or partially closes for a temporary amount of time the blood vessels and airways in the neck. As you can see from these red flags, there are some quite surprising elements to this, in that 50% of victims have no external injuries. The acute phase, so the time when you need to be thinking, I ought to get some help for this person, is up to 6 weeks after the event. Now, that to me doesn't feel particularly acute, but that is what the guidance suggests. So just having that in your mind is really important. Move to the next slide. Right. I want to also think about the language that people use. I don't think a lot of people will come and say, I have been strangled or I have been suffocated. There might be other words used, and I've used some of that here. Some people may experience this as part of their consensual sexual routines, but legally a person cannot consent to anything that risks their life, could lead to death. So consensually is not part of non-fatal strangulation and suffocation. We need to think quite hard about domestic abuse and whether there's any coercive control within that relationship. And again, people may not recognise this and present saying, I am being coercively controlled. They're more likely to tell you other little whispers about feeling frightened or having to do something because that's what works best for us, or walking on eggshells, or just other little hints to coercive control that need your professional curiosity, that famous buzzword. But it's important, isn't it, to just ask that next little question. Ask about feeling frightened and scared. Ask about the control dynamics within a relationship. And this is really relevant because it does then lead to other higher risks of harm to your patient. Right, I have included this rather busy slide, so I should make sure that you've got hold of this slide pack separately so you can have a better look at these different symptoms. Half of our people who present with non-fatal strangulation will have no visual signs. On here, there's some very obvious visual signs, so I'm going to skip over those and talk about the non-visible. So things like the impact on the brain function. People might have problems with their memory, changes in their behaviour. Their speech may be different. Some people may present with headaches. Now, we see so many people with headaches. How do you decide who to ask? I think it is relevant to plant that seed, to ask that question. Ask anybody with headaches about domestic abuse, about the possibility of restricting airway and blood supply to the brain. Because even if you don't get a disclosure at that point, it might just make them question something that they presumed was part of their normal relationship. Patients may also present with more peripheral motor and sensory loss issues, with continence issues, both with ringing in the ears. These are all quite vague things. We might be less surprised to hear about voice changes or problems with a sore throat or with swallowing issues, even drooling because of swallowing issues, discomfort in and around the neck. Now, again, that might be associated with some physical signs as well, some visual signs, but people with ongoing changes to their voice, maybe they are trying to tell you about their abusive relationship, or maybe they haven't actually linked that together. Maybe they haven't linked having that incident with the pressure on their neck to this. Now they've got an issue with a sore throat, but they don't feel virally, they don't feel unwell. And it's up to us to try and decide when that's appropriate to try and tease out. We'll be talking more about routine inquiry with domestic abuse on later slides, but obviously that is quite a useful time to be asking. So this is some information that goes along with the flowchart. There is a flowchart that has been developed by myself and people in the ICB, along with senior clinicians at Sheffield Teaching Hospital and their safeguarding team. The reason that it's important to have that joint piece of work is there's nothing worse than phoning somebody and them not knowing what you're expecting. So by having this joint flowchart, both primary and secondary care hopefully will understand the interface and what's expected of both of them. We also need to remember with this that this person is at high risk of harm, and therefore, because they're at high risk of harm or potential death from domestic abuse, we need to raise a concern for that adult using the domestic abuse form, so a MARAC referral. We also need to decide and consider if this person has any other care and support needs, in which case are those support needs meaning that they are not able to protect themselves from the harm from this partner, and therefore that would raise a safeguarding consent as well as the MARAC form. We also need to think about whether there's any other children in the household or anybody else that we might need to raise a concern in order to advocate and improve their safety. I must mention that at the moment, the MARAC, which I've presume that you know about, is the Multi-Agency Risk Assessment Conference. So the top 1% of severe harm from domestic abuse gets discussed at this conference. Unfortunately, in Sheffield, we have a waiting list for that, and due to that current delay, there is an unacceptable period of time for that person to be at ongoing risk when we know about it. I think the waiting list has been up to about 6 weeks, so incredibly vulnerable patients are at risk for a long time. Therefore, you raise the MARAC concern as per usual, but we also need to be contacting the police using the 101 number. Because these patients are at high risk of harm and death, and therefore the level of coercive control is so high that they're unable to make a unbiased, uninteracted, they've got the coercive control influencing their decision making. We are allowed and we should refer and make that phone call to the police without having to have their consent. I would always inform the patient that you are doing this, but explain why you are not going to resist referring them if they don't want you to. You have to refer. Very difficult because we are there maintaining relationships, but what we can get from the patient, from the person, is what is the best way for us to contact them. How can we reduce any the consequences, and what is their fear about this referral to the police and to MARAC. Right, so next slide. This is the pathway. So basically what we're trying to do is to get gather enough information to decide, does this person need to go to A&E right now? Their an immediate medical assessment is needed, and that's where we look at the red flags. Or are they going to see us as a GP and we can do a slightly slower but an urgent referral rather than emergency, get yourself to A&E. And this is all related to the high risk of stroke due to that damage to the carotid artery and the blood vessels in the neck. So we are, we're acting quick on this. This is a one-page pathway flow chart, but I split it up so that we can look at it in a bit more detail. Right, next page. This has got the information of where you send them. So we've got the red flags. That's A&E. Off you go. Good past go. What I would also say at that point is we need to make sure that we log in our brain that this person is at high risk of domestic abuse and harm, and therefore we need to consider their clinical management and their domestic abuse management and make a note to contact that patient after their A&E attendance. That is really difficult. A&E will also assess the domestic abuse and do their raise the concern appropriately, but let's just do belt and braces and make sure that we have done that referral too. So what we do if they are not off to A&E, but they're still at high risk of harm, they're in that 6-week post-event window, we're going to phone the stroke unit via the registrar bleep. Hopefully, and I have had good word back, this is working, and if the registrar doesn't understand, then the consultant knows about the pathway, so just bear in mind that you might need to mention it, but it wasn't too much of a big deal. They will decide when that person needs to be seen next and what steps there are. So they have a hot clinic where they can bring people up to. They will arrange scans. They might have a slightly slower follow-up service, but they will arrange the appropriate pathway. Now, what do we do with young people who are aged 16 to 18? So domestic abuse does apply to them, but they're not an adult yet. So we have spoken to the doctors in A&E in the Northern General, and they can attend adult A&E for their care input. Children under the age of 16 who are experiencing non-fatal strangulation and suffocation will go to the Children's Hospital and appropriate advice will be sorted from that end. Right. We'll leave you to read that more yourself. These are the highlights. These are the highlights for me. Here's your red flags. Here's the ones that we should be looking for when we see somebody up to 6 weeks. What to do with children, what to do with adults. That's the piece of paper that I would have on my desktop somewhere. Right. This page is about thinking about how we're going to document it. We've said that this is high risk of harm and therefore we're referring to MARAC. So we do need to put that information in the records, making sure that it's easy for clinicians to see, but not for other people who are viewing those online requests for the notes. I put some recodes in that you as a practice need to decide which ones you're going to use, how you're going to use it and when. This is also the point where you're taking a deep breath because you've dealt with the clinical situation. You think through all the other people in that household, remembering that children in that household are victims in their own right, and we need to refer them to safeguarding. This piece of work was initially started in response to a domestic homicide review for a lady called Lucia. I put a quick overview on this slide for you to read, but if you are interested, there are more details on the SASP website, and I can give you details for that. You can either email me or your safeguarding lead might know where to find them. I think it's important to have a think about the changes that can be made in your practice. People are familiar with the guidance packs will recognise that this is one of them and that you can repeat this training in your own practice. I would like you to have a think about how the information today could be disseminated, but also, do we need to change any policies? Are there any particular targeted inquiries that we need to consider? So, when we're talking to people that we are aware there's domestic abuse in their relationship, do we ask them about non-fatal strangulation and that element of behaviour? Have a think. Anyway, it has been lovely to talk to you all. I hope you found that useful. As I said, the Lead GP Teams channel has got the full pack of slides and some other information. If you have any comments or you want to raise any queries or questions or suggestions, please contact me via my email. All lowercase, Lampard@nhs.net. Nice and simple.